couple questions from yesterday, just review questions. We talked about a biological warfare agent. We talked about a couple actually. What was the species that belonged to the genus Yersinia? Pestis, right. And how is pestis primarily transmitted? Oh man, I should put that as a distractor on the exam. We're talking about bubonic plague specifically. Exactly, flea bites, yeah. And if it's pneumonic plague, is it the same method or do we have a different? Aerosols, yeah, exactly. Earlier when we were in the third deck about gram-negative bacteria, we were talking about some enteric bacteria. There were a couple other species in that same genus that caused gastrointestinal disease. Asked you guys this yesterday. Enterocolyticus, yes. And then the other one was pseudotuberculosis. Okay, very good. Going back to biological warfare agents, so Yersinia pestis is one that we talked about. What were some of the other ones that we hit upon yesterday? Brucella, yeah, exactly. So Brucella species that cause brucellosis, exactly. Anything else? Say again?
Trench one.
Yeah. So that Bartonella is not actually a biological warfare agent, but is associated with wartime conditions where there's not access to good sanitary conditions. So think about like maybe deck 3 to recover any biological warfare agents. Yeah, and that was actually deck 4 early on, I think, right? Yeah. So somebody said Burkholderia. We talked about 2 species in that genus. What were those 2 species in Burkholderia genus? Malii and Pseudomalii. Are both of them biological warfare agents? Or just one? Both of them are, yeah. Which one of those 2 species is associated with melioidosis? Pseudomalii. And which one is associated with Glandy and or Farsi? Flanders. Flanders or Farsi? Malii, yep. There's a geographic component to Burkholderia pseudomalii, the one that causes melioidosis. No, what bacteria is nicknamed Arabacter? Is Cimetobacter. But I'm talking about Burkholderia pseudomalii. There's a nickname for it that gives you a hint as to where it's endemic in the world. It's associated. Say again? No, that's Bartonella quintana, or Bartonella bacilliformis, sorry. No, so Bartonella pseudomalii, it's the one that's associated, at least when we had troops for the U.S. coming back from Vietnam back in the 70s. Very slow burn incubation time, months to years, so it got the nickname Vietnamese time bomb. And if you associate that with Burkholderia pseudomalii, you can kind of remember that the regions where this environmental bacteria are most prevalent are in Southeast Asia, particularly in like Vietnam, and in Northern Australia. Let's see. In terms of just going back a ways, just to hit upon something that's really important that we've talked about before, with E. coli, intestinal infections caused by E. coli. Just want to give you something presented as sort of a clinical vignette because some of you were asking about how to differentiate like diarrheal diseases. Say you have a patient with non-bloody diarrhea. They have a travel history. They've returned from someplace. The stool culture is negative for Shigella, Campylobacter, and Salmonella. But you do grow up some E. coli, which are normal gut bacteria anyway, so you're trying to find the significance of that. And you run a PCR on that stool, and you get positive ST and LT in that PCR. ETEC, enterotoxigenic E. coli. Yeah, good job, Shweta. Okay, so that's kind of something to just get you thinking a little bit about how we could use diagnostics to give us some information on getting to natural etiology. The 5 pathotypes of diarrheogenic E. coli. Somebody give me the 3 non-invasive ones.
EAC, ETEC, EAC.
Just give me the alphabet, like which letter?
E.
Incorrect. I mean like enero.
EAC.
Yeah, EAEC, and the A is stacked brick morphology, aggregative E. coli. Yeah, very good. And you guys are doing fine. Like this is typical, so don't feel like this is fine. This is why we review, right? All right. So there's one. Dakota, what was another one that you recently mentioned that's non-invasive?
ETEC.
No, that's the same thing, right? ETEC and STEC are.
No, EHEC and STEC are the same, but you mentioned LT-ST toxins in which serotype?
ETEC.
ETEC, yeah, so that's another non-invasive. So we have EAC, we have ETEC, a more toxigenic strain that has heat stable toxin and heat labile toxin. And then we have one more non-invasive serotype.
Is it ENEC? EPEC.
EPEC, yes, and the P stands for what? Pathogenic, but you should think of what kind of things when you're thinking about pediatrics, pedestal, patchy, yeah, good. Okay, and then the invasive pathotypes of E. coli,
ENEC.
intestinal E. coli are which ones?
ENEC.
EHEC, yeah, which is hemorrhagic,
Right.
and then EIEC, and the I stands for invasive. So the two invasive pathotypes, EI, invasive, and then S-type EHEC, which we're treating about the same, but bloody diarrhea, invasive types, can result in damage to the intestine that results in bloody diarrhea. A couple other enteric bacteria that can cause bloody diarrhea outside of E. coli. Shigella, yeah, Shigella, and there's one more, very, very, very common, most common cause of gastroenteritis associated with undercooked chicken. Campylobacter. Campylobacter can cause bloody diarrhea. Most of the cases aren't that way, but it can cause that.
It's gonna suck.
But you'll get there. We will do a very thorough review on Tuesday. Okay. Enough torture. Yes.
Speaking of torture, I have a question. Have you ever seen people wash chicken with soap? You've never seen it?
You have?
You've never seen it?
No.
You ever heard of it?
No.
That's just a
It's
you
a thing.
thing.
Really? Okay. Yeah, I hadn't heard. I mean, rinsing perhaps.
There's certain demographics that different.
Towel drying, maybe. I don't know. But yeah, I have not heard of that.
Soap.
Yeah.
I don't do it.
Sure.
Took by washing it with soap.
It's been a thing on social media, like washing your chicken with soap and warm water.
Oh wow, I've never heard of that. I've never heard of that. I will look into it. I will say, you know how I was telling about, cookie dough, raw eggs, and just eggs in general, if you're cooking or baking and you're cracking eggs, and how oftentimes there is salmonella associated with those eggshells. You're not supposed to wash the eggs. I have heard that. You're not supposed to because there's like some sort of protective covering on the eggshell, something like that. So I know, but the washing the chicken itself, I will definitely look into. It seems a little bit like overkill.
Well, it's pre-washed.
I mean, you are gonna cook it, right?
The eggs are always bleached. That's why they're white. They're bleached. Like they're super white. They bleach the
I
eggs.
don't
Like, when you buy them, they're bleached.
So we'll get started today, and then I think we'll take it easy. So I was hoping, or at least entertaining the possibility of canceling lecture tomorrow. I don't think that's a good idea. I think there's too much left to go because we have Inspired Keats to get through today, 10 slides Inspired Keats. So let's just take our time, go through the material today. We'll start the 5th deck today, the gram-positives. And then we'll kind of leisurely go through the first genus, Bacillus, which has anthrax, which takes a hot minute to cover. So, and then that'll be it for today. So it'll be a relatively small number of organisms because you guys got a ton of organisms yesterday. And then on Wednesday, we'll stretch our legs with the remaining 20 slides in the 5th deck. Okay. and then bigger view on Tuesday. All right, I'm gonna try and wear this thing again, and hopefully there's not that feedback issue. All right, so we're talking about the spirochetes now. If you remember, we briefly talked about these guys as a group that has morphological similarities, but otherwise not too much relatedness, and certainly not a lot of relatedness as it pertains to the disease they cause. That shape is a characteristic kind of sinusoidal wave morphology, where they're like 100 times longer than they are wide. It makes it difficult to ground stain them, impossible to ground stain them. You might be able to see them with other stains like Giemsa, but this is where we rely on dark field staining, like up here. This is a GIF. I know it's super faint, but with the lights on especially. But you can see some of the motility of some spirochetes on this dark field stain, where the spirochetes themselves are lit up, but the background is nice and dark. They do, for these for motility, they have those endoflagella. So these are not those nice external, highly antigenic flagella that we were talking about when we were talking about that Enterobacteriaceae members. But they may have anywhere between 2 to 100 of these endoflagella sort of woven into their bodies, along the axis of their bodies. Different genera have slight differences in the morphology. Like Leptospira, the last one that we'll talk about today, has these, the endoflagella more concentrated on the ends. And because of that, it sort of has this relatively flat body length, but then at the ends, it's like hooked. This characteristic hooked appearance. Borrelia, in contrast, has endoflagella woven throughout the length of its body, so you have just an even flat wave pattern with Borrelia. In terms of functionality, all of these genera of bacteria, all these spirochetes, need to be able to move through liquids. So that motility, that corkscrew motility, is how they're able to move through viscous liquids out in the environment. If they're environmental, like Leptospira is environmental, or if they're just moving through a human host, like treponemes that can cause syphilis. So we'll talk about syphilis first. This is a very famous disease, a very old disease. Very famously, like Columbus, when he was exploring the New World, is thought to have picked up syphilis, and his crew member brought it back to Europe, where it became endemic in Europe as well. But prior to the Columbian era, this disease was not really present in Europe so much. So old disease, very famous for some of the symptoms that it causes, particularly when you get to tertiary syphilis, where you have neurological problems, and it can cause madness and death, like the madness of King George, for example. He was thought to have syphilis. Al Capone probably died of syphilis. But the way it initially starts off with primary syphilis is through sexual contact. So this is a specific human-only disease. It's transmitted from human to human. It makes sense for an STI if you think about it. The primary syphilis is the spirochetes are transmitted through breaks in the skin during sexual contact. And you get these ulcers called chancres. We talked about when we were talking about chancroid ulcers with Haemophilus ducreyi the other day. We contrasted the appearance and the appearance of these two different types of ulcers. Chancres, they have a different texture. They have a harder texture, unlike the softer texture of chancroids. And they tend to be painless. There might be a little bit of swelling, and you might get secondary bacterial infections that can cause pain, but they themselves are not painful, as opposed to Haemophilus ducreyi, where those chancroids are painful. And there's a lot of significant inguinal lymph node swelling as well. So if somebody has primary syphilis, about 10 to 20% of those cases will resolve on their own. If that person is lucky enough, if they're just willing for this to go away, they might get lucky and it might spontaneously resolve. Your immune system clears it and there's no more syphilis. A lot of people will go in and develop latent syphilis after that period of time. Around 40 to 65% of people will have latent syphilis, where that organism withdraws into immune privileged sites. It can go up into the lymph nodes, it can go into the spleen, and hide out for a while. They're not generally that infectious if it goes into that latent phase. And then another good percentage of people will progress from primary syphilis after a couple weeks to secondary syphilis. Symptoms of primary syphilis are mostly in that genital ulcer, but when you get to secondary syphilis, the bacteria have replicated and you become bacteremic. So some of these symptoms associated with secondary syphilis that happens generally, up to 2 months later, are this full body rash. So you get a rash all over the body. It's a maculopapular rash. It can go over the hands, all over the place. And this is another contagious stage of the disease. So both primary and secondary syphilis are contagious. Primary syphilis, you're shedding the organism from those genital ulcers. With secondary syphilis, you're shedding the organism both through sexual contact still, as well as through close contact with the skin, because the organism can be where those rashes are. So for diagnostic purposes, those are good specimens to take to if somebody has secondary syphilis. You're looking for the organism itself. In terms of the people who progress on to tertiary syphilis, which could take, in some cases, up to 30 years, a slow burn movement to tertiary syphilis, or as little as a couple of years, there's about 33% of people who have primary syphilis who go all the way to tertiary syphilis, particularly if they're not treated in that interim. With tertiary syphilis, we have another slide where we'll talk about some of these symptoms in more detail. But this is when the organism is causing a lot of damage, but there's also some significant immunopathology at play here too. One of the symptoms that is classic with tertiary syphilis is you get these deformations in the face along the soft tissue structures. Things like, these are called gummas that appear in the soft tissue structures. This historic photo of a woman with tertiary syphilis, you can see the cartilage in her nose has eroded away. And then in these pictures, these drawings, a lot of that soft tissue is sort of just deteriorated. Anybody seen that series with Emily Blunt called The English? It's a Western. I'm a single person that was 65. Oh, boo. Okay, it's really good, especially if you like Westerns. But kind of a spoiler alert, there's 8 episodes in this single series. She has syphilis. But it's interesting from a microbiology perspective, because you kind of get to see the deterioration when she progresses to tertiary syphilis and the face is deformed at that point. So, but yeah, those are like the classic symptoms there. And your body, in terms of the immunopathology, you form these structures around the bacteria that are sort of like granulomas. So your body is trying to contain those, and that contributes to the pathology of those gummas. Makes it inside of those granulomas, there's a lot of tissue destruction, and that is irreversible. So a significant portion of immunopathology at play there too. In terms of the more serious, life-threatening things that can happen during tertiary syphilis, you can have cardiac damage in about 10% of cases. You can have there's neurological defects, which there's a little bit more information on the next slide about some of those neurological defects. You can have damage to the vasculature as well. This can affect the ears, the eyes. So a lot of different systems can be affected by tertiary syphilis. With neurosyphilis, these are some of the common symptoms. You get dementia, problems with muscle movements. You have things, something like tabes dorsalis. Anybody heard of tabes dorsalis? You lose your proprioception, and I should have pulled a picture or a clip of somebody trying to walk who has tabes dorsalis. But when you lose your proprioception, you basically walk like you have like your feet, the muscles in your feet are no longer responding, so it becomes incredibly difficult to walk that way when you can't sense the ground and have your muscles coordinated appropriately. So things like that, trouble with muscle movements and others as well, headaches are all kind of classic signs of neurosyphilis. Ocular syphilis that can cause a lot of eye pain, trouble with visions. Otosyphilis as well. And then another form of syphilis is the congenital form, which is one of the most devastating forms. This particular spirochete can cross the placental barrier. So if a woman has syphilis when she's pregnant, and a spirochete crosses the placental barrier, spirochete can do lots of significant direct damage to the fetus. It can burrow through and cause damage to developing bones, to the brain. to the eyes, the ears. So some of these symptoms, if the fetus survives at all, which it may not, it may be killed in utero, are classic associations with congenital syphilis. And some of them are apparent pretty early on, and some of them take years to become apparent. For example, if you have damage to the teeth, you can get these notched teeth. It's called Hutchinson's teeth. This is not a comprehensive list. There are tons and tons of other things that can happen. You can have boned legs, where the tibia are affected in the legs, and that would be apparent later in life. Saddleback nose is seen in children once they start developing early on in life, where they have cartilage erosion in the nose. So a bunch of things like that. In terms of diagnostics, so depending on what stage of the infection a person is in, dictates what kind of diagnostic tests you have available to you. But microscopy is difficult unless you're using either fluorescent microscopy, in which case you have to fix the bacteria and kill them, so you wouldn't be able to see any motility there. Or again, if you're using dark field, where you could actually see motility because you haven't killed the bacteria. The image on this slide is showing the fluorescent microscopy. So, and they may have concentrated that sample too, because it looks like there are a lot of spirochetes that are lit up in that fluorescent field you're looking at. This bullet about, well, two things. They are difficult to culture, and most spirochetes are difficult to culture, so we tend to have other laboratory tests available. We do have PCR, but it's not FDA cleared. And there are a lot of limitations. There's some times where it might be appropriate to try and use PCR testing. For one, like if you want a PCR amniotic fluid, if you suspect there's congenital transmission, it might be an instance, but it's not really relied upon. And that's probably because of the fact that those tests aren't generally sensitive enough or specific enough. So because of that, we rely on other methods. Direct pathogen detection is sometimes used. That would be an example where you're looking at the organism themselves, like if you're getting an exudate from a chancre, that would have tons of organism for primary syphilis. And you could do microscopy on that and look directly at the spirochete, or fluorescence as well. You can do the same for secondary syphilis if you get a good specimen, but for tertiary syphilis, you probably would not be able to find a direct pathogen detection method. So we have some indirect tests that we can use also for detection. One of these, early on, we talked about, I think in block 2, we were talking about immunoassays, right? And screening assays that have really, really high sensitivity but low specificity. So syphilis is one of those diseases where we would use an immunoassay that has very high sensitivity but low specificity. And that's what this first couple tests are. The RPR and the VDRL tests are both very popular, inexpensive, rapid screening tests. Super sensitive, but unfortunately they are incredibly not specific. So you get a lot of false positives. This list are just some of the things that will result in a false positive. Some of these are very common. Malaria, leprosy, HIV, recent vaccinations, autoimmune disorders, pregnancy, and advanced age. So it's not a very reliable test, and because of that, if you want to do an RPR or a VDRL on a patient, you would definitely need to do a confirmatory test that would be more specific to confirm that diagnosis. Before I talk about those confirmatory tests, what these non-treponemal indirect screening tests are actually looking for, since they're indirect, is not the bacteria itself, but it's looking for something like indirect damage caused by the bacteria. So when these bacteria are causing infections, they cause cardiolipin to be shed, and that is what these tests are actually looking for, shed cardiolipin. That's called reagin. Reagin is some indirect evidence of damage that's caused by that organism. And that's what RPR means, rapid plasma reagin. So a lot of shortcomings, but then we follow up with a direct test. And these direct tests would be things like looking to see whether or not we have antibodies against Treponema pallidum. So one of those common tests is the FTA-ABS, the fluorescent treponemal antibody absorption test we can do. We also have EIAs, but the same principle applies. We're just looking for evidence directly that you have antigen from that organism threatening the pathogen. And those are, like I said, very, very specific. Let's see, I'm forgetting something with that. I'll circle back if I have forgotten something with that. Any questions on testing for syphilis? Okay. So we'll move on to Borrelia, second genus of spirochetes that we'll talk about. Borrelia is a genus that's associated with, at least the human-specific diseases, with arthropod transmission. So we talked about some arthropods that transmit diseases yesterday. We'll start off with talking about relapsing fever and the ways that you can contract relapsing fever. But the same genus is responsible for a much more famous disease in the United States. Anybody know? Yeah, Lyme disease. So in the United States, the organism that's mostly implicated with Lyme disease is Borrelia burgdorferi. In Europe, they also have Lyme disease, but it's caused by a different species. And I forget the name of that species, but it's a very similar presentation. So that's Lyme disease, Borrelia burgdorferi. But on this slide, we are talking about the lesser known Borrelias that cause relapsing fever, which is kind of similar in some ways. Relapsing fever can be transmitted by either lice or by ticks. There are a couple differences, but the fever itself is similar enough where we can kind of treat them together. And there are different species of Borrelia associated with the louse-borne versus the tick-borne transmission methods. With this epidemic or louse-borne relapsing fever, it does have a geographical restriction to these parts of northern and eastern Africa and Ethiopia, Eritrea, Sudan, and Somalia. But we talked about a disease yesterday, a louse-borne disease. Do you guys remember which one that was? Trench fever was a common name. Anybody remember the scientific name of trench fever? 5-day fever? Quintana, yeah. So that was a louse-borne disease, and it was associated with lice, which could be wherever people are, right? The human body louse, wherever people are. But you have to have crowded conditions in order to have infestations of lice and unsanitary conditions. So historically, it's called epidemic relapsing fever because we did have big epidemics of relapsing fever caused by this louse-borne form in the 20th century, but most of those were associated with wars. They were along Eastern Europe, Southern Europe, associated with World War I, World War II. Okay. So to these days, this is the area where it's concentrated, even though it's transmitted by this ubiquitous human body louse. Endemic relapsing fever is tick-borne. It's transmitted by soft shell ticks, which most tick-borne diseases are transmitted by hard shell ticks, so it's a little different in that respect. This is Ornithodoros, this genus right here. And we do get cases of endemic tick-borne disease in the United States, this relapsing fever. Most of them happen out west in states like California, sometimes up in Washington State, most recently from the cases that I've looked up on ProMed. And it's a different set of species. You don't need to memorize these species that can cause endemic relapsing fever, just to be aware that there are a couple other species of Borrelias that can cause the tick-borne form, and that we can get it here in the United States. That's always important to remember. In terms of treatments, doxy is sort of like doxycycline, this tetracycline, is the infamous treatment for a lot of tick-borne diseases, but this is still a gram-negative, even though it's a spirochete, long in skin, it's still gram-negative. So if you treat a severe infection, you can get, or has been linked to this consequence that we've talked about briefly, the Jarisch hexamer reaction, which is release of endotoxin. So that's a potential complication with treatments for some of these diseases. Okay, in terms of the symptoms associated with relapsing fever, whether it's endemic or epidemic relapsing fever, fever is the main symptom. It's like the classic hallmark, and the pattern of the fever is specific as well. These organisms don't produce any toxin, but their major virulence factor is the fact that on the surface of the spirochetes, they can change their outer surface proteins, their OSPs, and that can cause the immune system to reset and have to generate an adaptive response all over again. So by the time you develop antibodies against the surface antigens of the original infecting bacteria, those bacteria, the ones that survive, will be selected for, and those populations can start proliferating again. Because of that, you get these patterns of relapsing fever. So say you have an original infection where most of those bacteria have one type of OSP, you raise an immune response to that, and in the meantime that patient is spiking a fever, you clear the vast majority of those bacteria, I mean like 99.999% of them. But the ones that survive start proliferating, and then you get another fever. Those fevers can last between 4 to 7 days. And it has been documented, in cases of relapsing fever, you can get up to like 7 cycles of fever like that. Each one is usually a little bit less severe, but you can see how that would be like an exhausting thing to have to deal with. Okay, and then lastly we have Borrelia burgdorferi, causative agent of Lyme disease in the United States. So this disease is transmitted by hard shell ticks. Most of these ticks belong to this genus called Ixodes that is present kind of all over the United States. This map is showing a lot of cases out east, particularly like in upper Midwestern states and in New England. But we have genera of Ixodes called Ixodes pacifica in the western states as well. Scapularis is the dominant Ixodes species, sort of on the eastern side of the United States. In terms of the ticks themselves, just for you guys as people who are going to be seeing patients who have tick bites, these are kind of the major life stages of ticks. These are examples of Ixodes in different life stages. The big guy, that's the adult. Next to him, this is a juvenile. And then this guy is called a nymph. The vast majority of these transmitted cases of Borrelia burgdorferi are caused by these nymphs. They're significantly smaller and harder to see than the bigger adults and juveniles. So that's problematic. And then at the very tail end there, you have the larvae. So these larvae can be all over the place, but they're too little to transmit this disease. But it's the nymphs you have to worry about. Highest areas of distribution, this is where providers in particular are most on alert for Lyme disease. Wisconsin, Minnesota, and the New England states, like I mentioned, particularly in this like epicenter in Massachusetts, there are a lot of cases out there. Feeding time, we've all had tick bites, especially in the military, very common, right? We try to reduce the risk of this disease and other tick-borne diseases as much as possible by doing, what are some control measures that we use a lot in the military?
Spray.
Permethrin treatment of our uniforms. How long does that last? Yeah, so it will eventually go away, right? After enough washes, you have to retreat your uniforms. But that's a really effective way of reducing the risk of getting bitten by a flea. When you do get a flea bite, in contrast to some of these other arthropods that we've talked about that can transmit diseases like sandflies and like mosquitoes, where they just, it's not, how long does it take for a mosquito to bite you? Like a few seconds, right? So whatever they're carrying, they have to be able to transmit within that very short time period of a few seconds. But with ticks, they latch on for a long time. You can have a tick bite, especially if it's in a part of your body where it might not be readily visible. It can latch on for days. And it takes a long time to actually transmit Borrelia burgdorferi spirochetes from an infected tick to a human. Ergo, you should encourage people to get rid of those ticks as quickly as possible and do tick checks in a timely way, because if you can remove the ticks before they transmit the disease, you shouldn't have any problem with avoiding Lyme disease. It takes many, many hours to transmit this disease. Okay, so you get a tick bite. Let's say the tick has managed to latch on long enough to transmit Borrelia burgdorferi into you. It gets into your bloodstream and it starts replicating. Initially, you don't have too many hints from these initial symptoms. They're the general symptoms of fever, a little bit of muscle and joint pain maybe. Your lymph nodes might start to swell, but nothing particularly distinctive. So for this stage in particular, if a patient recalls being bitten by a tick, that's usually really helpful as in terms of clinical history. Do you have exposure to ticks? Important information to have. About 80% of people who have been bitten by a tick carrying Borrelia burgdorferi will have this characteristic bullseye rash. Some people are tempted to call it a pathognomonic feature of Lyme disease, but other things can cause this characteristic bullseye erythema migrans rash. There are other tick-borne diseases like Stari. I forget what that stands for, but it's another tick-borne disease, and that's here in Texas. But that will present with a bullseye rash like that too. So just because somebody has that bullseye rash doesn't necessarily mean that you can diagnose it as Borrelia burgdorferi, although it is pretty distinctive. And also, not everybody gets it. Just the vast majority of people, 80%, but still 20% don't get that characteristic rash. Other symptoms to watch out for, so this will be more during the acute phase. If that organism is not cleared by the body or treated by something like doxycycline, you can get other systems affected. One of the most common complications or other symptoms involved with Lyme disease is this arthritis. And usually this arthritis develops in the knee. So that picture is showing like the classic main joint affected when you have Borrelia infections. Another symptom that's classic and associated with Lyme disease is this facial palsy, sometimes called Bell's palsy, where you have like one side of your face that loses a little bit of control, and you get have a hard time smiling, you might be blinking, other things like this, like that. I had a friend in Virginia who had Bell's palsy, and her face was like, it was really, really noticeable, and she was really self-conscious of it, but it was interesting to kind of see that. Have you guys ever seen somebody with Bell's palsy before? Yeah, it's, say again? Which one? Which character was that?
Mountain.
They were
Okay.
big Thor Bjornsson.
I'll have to watch that again and look for that. I usually keep an eye out for like movies and TV shows that have an infectious disease bend to them. But yeah. But anyway, Bell's palsy, even though it's really well known and its association with Lyme disease is pretty well known, it only occurs, I think, in fewer than 50% of cases. So it's actually less prevalent than even this arthritis that you get. Another even more rare complication you get is sometimes you can see bluing in some of these joints, the discoloration of some of those joints. But that is, I think, around like 5 to 10% of cases, so much, much less common. Any questions on Lyme disease? For diagnostics, I'll get you guys in just a second. For diagnostic purposes, there are PCRs for this, and we can do limited microscopy, but culture is also not usually implicated or difficult to culture Borrelia. So clinical picture is important, the presentation, and after a couple of weeks, they should raise antibodies, so you can do serology on these patients and look for IgG. Yes, sir. You have a question?
Is this the same organism for the Texas Monster?
Like same genus?
Yeah, like same.
No, it's not. Hang on one second. I think I have that buried in my notes. What's that? The meat allergy one? Mysterious meat allergy? Yeah, I've heard about that. That is kind of a confusing topic. This organism that I was talking about, the one that causes, yeah, here it is. Okay, so in Texas, southern tick-associated rash illness, Stari. I'm so close to like picking on you, but I'm not going to yet, although I'd love it if you chimed in. It's an emerging infectious disease related to Lyme disease that occurs in southeastern and south central U.S. Spread by tick bites, hypothesized that illness was caused by a bacteria called Borrelia lone-starii. However, there's insufficient evidence to declare this Borrelia strain as a causative agent, so failure to satisfy postulates, basically. Okay, Do you have anything to add at all, Philip, on that, on Starry, or just, yeah, curious? Yeah. Yes, amblyomma, that's like dog tick, right? Yeah, okay. And with Borrelia burgdorferi, that is Ixodes, a different genus. I think it can be transmitted by other genera ticks, right? Yeah. Okay, but Ixodes is probably the main one vector for Borrelia burgdorferi. Oh, and sorry, there was a question over here too. Yeah, Sean.
The 24 to 48 hour infection.
Yeah.
Is that like just the amount of time that you need to get the infection dosed from the tick itself?
Yeah.
Something causes them to simply speed up.
I don't have a super clear understanding, but from what I understand, it's sort of like a trickle of bacteria rather than just a massive expulsion, like a flea bite where you get that entire plug released. I don't know. Do you know? Sorry to keep picking on you, but do you know anything about the transmission over that long period of time when you're transmitting spirochetes from a tick bite? So is that happening like all at once, the transmission of bacteria during that period? Yeah. Okay. So, and actually that reminds me. So when we were talking about relapsing fever, and we were talking about endemic tick-borne relapsing fever transmitted by the softshell tick, Niphodoros, that is one of the fast transmission events. So this happens with a limited latch time. I don't know exactly how long that takes, but it's much, much faster. Contrast that to Borrelia burgdorferi, Lyme disease, longer latch time required. Any other questions about Lyme disease or Borrelias? Yes, ma'am.
So even if the tick is removed in time, if it's removed incorrectly, then it can still transmit disease, for example, the
Yeah, seeing some head nodding there. But if the mouth parts are in there and the bacteria are in the mouth parts, and that mouth part stays in the skin, it can continue transmitting. The bolus of the bacteria, though, correct me if I'm wrong, but it's in like the midgut or foregut. Okay, so it'll stay in the salivary glands. Okay, so if you're pulling out the body of the tick and the head remains attached, the salivary glands will be there to continue to transmit. So, yeah, in terms of tick removal, I haven't had to remove ticks from people in a while, but back when I was an engineer in Bullock, for some stupid reason, they had me being like the official tick removal person for that entire class. So guys would come up and be like, oh, I have a tick in my armpit or a tick someplace else, would you remove it? And I must have removed like dozens and dozens of ticks. This is about 15 years ago or so. I kept them alive for a while, just to study them. And I watched them as they when they're engorged, they're huge, right? And then I watched them sort of starve to death and they get really flat. And it's really sad, but it's interesting. And that's before I was a microbiologist, so I was like, yeah, maybe I should do something that's more in line with my interests. But yeah, when you're pulling ticks off of people, especially if you're pulling ticks off of soldiers and you've been out romping around in the woods and forests and you're picking up tons of ticks, you have to be super careful. There's some bad advice out there on how to get rid of ticks and some good advice. So if you're advising patients, make sure you're telling them the proper ways to get rid of ticks so you don't have that issue where the head is stuck there in the skin. You can also get some secondary bacterial infections that way too. Okay, let's take a 10-minute break and then we'll do actually, do you guys mind if we just finish Leptospira and then we can start the new deck? Okay, cool. Let's do that. Yeah, 10:46, we're fine. Okay, so the last genus of spirochetes we're talking about causes leptospirosis. If you've ever heard about that. It is a rare disease in the United States. We get about 100 cases a year of leptospirosis. And mostly the states where that occurs are warmer places. If you count Puerto Rico contributes to some of those cases. We did have an outbreak in Illinois, of all places, in 1994, and that was associated with a Tough Mudder. People that were, people who were participating in this adventure race where you're swimming and crawling through muddy water and a bunch of other stuff like that. Really good way to contract or encounter leptospira. So what is associated with this environmental bacteria is the ability to survive in lakes and rivers outside of any kind of host. There's no arthropod vector involved, so it's mostly an environmental bacteria. It can survive out in water for a long period of time. And then there are reservoir species of animals that come into contact with this environmental bacteria in the water when they drink the water. And these reservoir species can harbor these bacteria for significant periods of time as well. Rats are big reservoir species, sometimes livestock. To a lesser extent, dogs and cats, skunks, things like that. These animals that have leptospires in their system, those leptospires will go into the renal tubes, into the kidneys oftentimes, and then these organisms kind of get shed fairly consistently in their urine. If the urine from animals who are carrying leptospira gets into water supplies, it kind of repollutes that water. And where humans pick this up is when they're in contact with water that that's been contaminated with animal urine, basically. This picture is showing a dog near a puddle. The dog is licking up that puddle water. We obviously wouldn't do that, but what we do is participate in things like adventure sports and things like that. Waterfalls, people who want to go near water sometimes pick up leptospirosis and are implicated in some of those rare cases that we get. So that's a primary mode of transmission. If you do have leptospirosis, which can become a very dangerous disease, you will not be shedding it in a way that is transmissible person to person. So you're getting it from water, environmental water. In terms of the presentation here, there is a significant number of people who come into contact with this bacterium, probably at a low inoculum, who are subclinical, so they have no infection at all. Another good chunk of people will have only mild symptoms, these mild flu-like symptoms. So it's oftentimes mistaken for a viral illness early on because you get the fever and the chills, headache, and body aches. However, a small percentage of people can get some really severe presentations that start mimicking, or really they are, in a lot of cases, impacting the liver and other major organ systems. So with wheal disease, which is one of the more severe presentations, you get these signs and symptoms of jaundice. Talked about jaundice before briefly, but here you can see the picture on the top, a really good example of somebody who has icteric symptoms. Icteric just means symptoms of jaundice. Yellowing of the eyes and then yellowing of the skin. And that's evidence that the liver has been affected. So the liver is supposed to be filtering out toxins. When it can't do that, some of those toxins will eventually end up in the skin, and you get yellowing skin, bilirubin in the skin, and also sometimes itchiness because of the toxins that are in the skin are irritating there. He has subconjunctival effusions as well, so the whites of his eyes are starting to redden a little bit. That's common with severe leptospirosis as well. You can get meningeal symptoms as well. That's not on this slide, but it's just something to kind of know that is possible. And another characteristic feature of more severe leptospirosis is this rash that sometimes can develop. That's an indication of vascular hemorrhage that might be going on. That rash is usually going to be on the lower extremities, like in this picture. So this guy has it from his calves on down. With this more severe presentation, mortality rates are between 10 to 15%. Let's say about that. Yeah, what I was gonna say. But might be difficult to diagnose if you don't have these really dramatic symptoms that are characteristic for severe leptospirosis. Just clinical history, and if they've participated in something that would put them into contact with contaminated water. People who spend otherwise healthy people who spend a lot of time outdoors, they might have a travel history. You can also do some serology and see if they have developed IgG against Leptospira interrogans. All right, any questions about Leptospira? All right, let's start back up at 11:01.
For what? That's it. No, it's not.
The issue is just, it's hard to justify because it's so rare.
I hear about it in the news. That's why I don't like to steal bodies of water.
I'm assuming you stayed.
And it could make it sound like
So body because like adventure is that's the body.
Yeah.
Like you could be finding some